All right. Hi everyone. My name is Jarrah Aburezq. I'm a PGY2 at PGY2 urology resident. Today I'm going to talk about day surgery in urology. Thanks to Dr. Forbes for supervising the presentation. Yeah. So, learning objectives, we're going to go through just a review of the relevant history of outpatient surgery, and then outpatient surgery in urology specifically. Describe the motivation behind transitions towards outpatient surgery, highlights relevant literature trends towards outpatient surgery, and then discuss feasibility and obstacles to implementation. So I'm going to start off with the history of outpatient surgery, describe some of the driving factors, outpatient surgery in urology, and then do a literature review of various procedures, and then discuss limitations to ambulatory surgery and conclusions. So a brief history. One sec, this is covering my notes. So outpatient surgery today is considered a relatively recent phenomenon, but one can't look back without noting that from technical aspect the very earliest surgeries were in fact outpatient procedures. The earliest concepts of medical procedures were in fact performed in patients' homes and where they stayed to recover afterwards. Later on, religious orders began to form and operate hospitals for the indigent and infirm. And hospitals, from their development, were a mixed blessing. They provided much needed care at a specialized center while contributing to major complications related to infection. Today's hospitals continue to have similar challenges, albeit in a modern and sophisticated setting. If we go to the 1500s, surgery as a concept started with tradesmen performing simple procedures like treating wounds, draining abscesses, treating fractures. And an interesting fact, they would hang a blood-spattered white bandage outside their shop, which lives on in barbershop signs today. By the 1800s, near the time of the Second Industrial Revolution, this expanded this tradesman skill into a proper discipline and what surgery is known as today. And what changed our discipline and developed it into a proper profession was our ability to overcome three major obstacles that forever plague our profession, which is bleeding, pain, and infection. And these are the same three obstacles that are the main focus for many innovations in our fields and important obstacles to outpatient surgery. The history of ambulatory surgery in 1918, Dr. Ralph Waters opened the Downtown Anesthesia Clinic in Iowa. And this is the first documented general anesthesia given for ambulatory surgical patients. Neither the public nor the medical community embraced this concept. It was a failed concept. The clinic was not successful in the long term. And then more recently, more recent historical developments began in the 1940s and 50s when surgeons began to embrace the concept of early post-op ambulation and early recovery from surgeries. In the 1960s, physicians began to note and document that a lot of emergency department patients were discharged the same day after simple procedures that were done in the emergency department. So that they began to provide these minor same-day surgeries. And that was the idea, that the same-day discharge was for procedures that required little to no anesthesia. The first outpatient-based surgical program in a hospital began in 1961 in Butterworth Hospital, which led the way by opening what is considered the US's first established ambulatory surgery program in a hospital in Michigan. And then freestanding ambulatory surgical centers followed, which were spearheaded by a big center in Phoenix, Arizona, which opened in 1970. And in that center was mostly a mix of GI procedures, some gynae surgeries, and ortho surgeries. The nice little graph I have there is just the day surgery data for in the US is all that I could find. And so same day same day surgical discharges were recorded to be around 16% in 1980, and this went up to 50% in 1990 after this bloom in the 1980s, and then in 2010 and around now, every two out of every three surgeries are performed as an outpatient in the U.S. So why this push towards outpatient surgery? So with most driving factors of most things in the world, it's financial. The term outpatient was actually first used in the literature by Dr. Benjamin Waterhouse in 1808, where he called a group of patients outpatient, and the goal was to decrease the bill of his hospital by decreasing what he called boarders or inpatients. So from the very start, the concept of outpatient was a financial concept. It's been shown that outpatient surgery costs about 40 to 60% less than the same procedure done as on inpatients. Patients benefit directly from reduced costs for the self-pay procedures for patients without insurance or procedures that are not covered by insurance. And they also benefit indirectly from reduced time off work. Another driving factor was advancements in anesthesia. So propofol was first synthesized in the 1970s. It had a rapid and smooth effect. It had a rapid recovery, and this contributed to the 1980s bloom or a jump in outpatient procedures. They also developed local nerve blocks, which facilitated outpatient procedures, and then some advancements in technology, so laparoscopy, robot surgeries, endoscopic procedures, shockwave lithotripsy, and even some techniques in open surgery. All these minimally invasive techniques have dramatically reduced tissue trauma, blood loss, pain, and surgical morbidity after a wide range of procedures. And lastly, attitudes. So attitudes of patients, attitudes of healthcare providers, and attitudes of hospital administration. So the general acceptance and encouragement of outpatient procedures. So patients are far less hesitant. When you tell a patient you're going to perform a procedure and they're going home the same day, they're a lot less anxious. They like the fact that they go back to work quicker. Their scheduling is a lot more convenient. They also perceive the quality of their care very differently, and their satisfaction rate is typically a lot better. Their pain rate is typically a lot better. Surgeons theoretically benefit from decreased workload, better scheduling, minimal paperwork, some time saved of not having a bunch of inpatients to see. And lastly, administrators or hospital administrators obviously push for the obvious financial advantages and the scheduling advantages. And there's also the bed shortages aspect that affects scheduling. I talked to a couple of anesthesiologists at VGH that specifically mentioned how much bed shortages are affecting surgical scheduling. And again, obviously, I don't have any exposure to this, but they say that urology supposedly is feeling this quite a bit. I like this quote. I saw this quote in a paper called "Changing Trends in Urology Practice: Increasing Outpatient Surgery" by Dr. Keith Kay in 1995. He says, "It will probably be by the end of this century, the question will not be whether a patient is suitable for treatment on an ambulatory basis, but whether there are any indications for admission." So with that, talk about urology. Urology has always been at the front of innovation in surgery, being the first to adopt new practices and push for new developments. Our field has also contributed significantly to the development of outpatient surgery. There's a long list of procedures that are now almost universally done on an outpatient basis. So ureteroscopies, hydrocelectomies, vasectomies, etc. Procedures that require little to no anesthesia, which were the basis of outpatient surgery, have now been transferred even to in-clinic. So flexible cystoscopies, biopsies, Botox injection, and some procedures for BPH. The limits of what can or can't be done as an outpatient are quickly evolving and being pushed. Many studies are focusing on proving that inpatient procedures can be safely performed as outpatient procedures with no increase in complications. And obviously, a lot of these studies are from the US, given a strong drive to decrease costs with their healthcare system model. I also wanted to focus on the feasibility aspect. What logistics many of these studies have access to that pose obstacles to implementation universally? Why is it that a lot of these procedures have this documented, long-standing history of being safe to be done as a day surgery, but it's not being universally adopted or implemented? So with that, we'll start with the bread and butter, ureteroscopies. So NITS in 1879 pioneered the first modern endoscope for cystoscopy. Ureteroscopy has obviously come a long way over the years. This is a picture of the first modern cystoscope. In 1930, or sorry, 1929, Dr. Youngs and McKay put a 9.5 French scope up to a pediatric renal pelvis. In 1980, Dr. Leon dilated a distal ureter with Jewett sounds to 16 French and then passed to 14 French into the ureter. By around 1980, we had developed the small fiber optic scopes that inspect the urinary tract. What I'm trying to highlight here is our specialties is highlighted with figures who push the limits and lead in the innovation and led to the innovations we have today. The first study describing results of ambulatory ureteroscopies for laser stone fragmentation was published in 1998 by Dr. Yip et al. He looked at 69 patients, had a 10% complication rate and a 6% readmission rate. And obviously, this kind of developed over time. And the study showed that rigid ureteroscopy for ureteric stones can be performed on an outpatient basis with an acceptable kind of readmission complication rate. And then several other studies followed. And then this was kind of implemented in most places, obviously, since here in North America. It's a short procedure, low complication rates, literature has been established. Despite this, there are some centers in other places around the world who haven't implemented this. There's a meta-analysis comparing PCNLs to URS in the UA, which noted that the average length of stay for URS in Europe is about 30 hours. In the Middle East, where I worked briefly in urology, there are some centers that still admit ureteroscopies overnight. Typically, they put a polyp catheter in and then remove that post-op day 1 or 2 instead of a DJ stent. Next, PCNLs. So the initial PCNL was actually described in 1976, and it involved putting in a nephrostomy tube, and then a Cuvelier catheter was inserted, and then this was slowly dilated by increasing the size daily. And then after they reached the size they wanted, they left the tract to mature for 2 weeks, and then they removed the stones with fluoroscopic guidance. And that landmark development led to the birth of endourology. And then since 2000, obviously, the PCNL has made open surgery for complex stones pretty much obsolete in most countries. This slowly evolved into the minimally invasive method that we use today. The initial length of stay was about 8 days, and then over time this developed, and for the longest time the gold standard was to admit patients for about 2 days post-op for a variety of reasons, like monitoring for bleeding, sepsis, giving IV antibiotics, pain control, and the gold standard was, okay, leave an F tube for 2 days and then send him home. In Europe, the average length of stay noted was about 60 hours, so 2-3 days. But outpatient PCNL was first described in 1986. And then with the development of tubeless PCNLs, which is using DJ stents and no nephrostomy tube, there's a reduction in pain, there's a shorter hospital stay and recovery time, and it's been established to be safe to send them home the same day multiple times in literature since that 1986 study. There are some patient factors that limit PCNLs being safe as an outpatient. So comorbidities, obesity, which increases like the distance to the stone, and stone size, which would, or stone burden, that would increase the length of the OR. But again, it's been described multiple times since 1986, but it's still predominantly an inpatient procedure. The initial 1986 study, their inclusion criteria was they just recruited a bunch of young men with no comorbidities and stones less than 1 centimeter. These limits have obviously been expanded since. Most studies exclude the comorbid patients that are and any patients that are overly obese or have very large stone burdens, which would necessitate longer ORs. But then a recent meta-analysis by Gassman et al. In 2024 published a comprehensive review including 13 very large-scale studies comparing outpatient to inpatient PCNLs. They found that the complication rate for outpatient PCNLs across these studies ranged about 0 to 20%, which is in keeping with the average for PCNLs in general globally, around 20.5. And within these studies, some studies extended the criteria even further, and they included what they called extended criteria cases. So this is patients with an ASA score of over 3, an age of over 75, BMI of over 30, stone burden of over 4 centimeters. They even included solitary kidneys, transplant kidneys, and they found, again, it's completely safe to send these patients home same day. They found no differences between the extended criteria and the standard criteria patients. The first study I wanted to kind of hone in on or focus on is a study that I headed in Calgary, where I looked at over 300 patients comparing outpatient to inpatient PCNLs. And Calgary was a great center to do this because there are three endourologists, two of which performed the classic PCNL, where they stuck neph tubes in, and the estimated length of stay was 2 days, versus one endourologist that discharged the patients home the same day. The outpatient group underwent mostly upper pole access. They all had DJ stents inserted, and they all underwent a CT on post-op day 0 before going home. The inpatient group all had nephrostomy tubes inserted and underwent a nephrostogram on post-op day 2 and then got sent home without a tube. We didn't find any significant difference in UTIs. There was no difference in complications. There was an increased number of emerge visits for outpatient PCNLs, but that was mostly due to stent colic because they all had DJ stents. And then we also did a very comprehensive price analysis and found that including the price of the emerge visits, including the price of any scans done, including the price of any staged treatment or ancillary procedures done, the cost per patient was decreased by about 42%. So the important takeaway from our project was, yes, it is just as safe to perform PCNLs on an outpatient basis in terms of post-op complications, which is something that's been demonstrated in the literature multiple times over. However, the logistics of day surgery was not as straightforward. So if you see here that the same day discharge rate for outpatient PCNL is only 73%. So why is that? So if we look here, you can see our data showed that initially, even though we wanted to send all the patients home the same day, the patients were going home about 40% of the time, and this increased to 100% over the 2 years the endourologist worked at the center. A lot of logistics had to be ironed out for same-day discharge to be feasible. Figuring out which patients qualify, gaining more experience and comfort with the day surgery nursing staff and the surgeon, figuring out how to deal with patients' increased phone calls post-op, discussing post-op day 0 CT scans with radiology. These are logistics that were slowly discovered over time and took administrative workaround and were perhaps originally overlooked. Fahmy et al. In 2016 reviewed 186 patients that met their strict inclusion criteria for same-day discharge. Their patients had no comorbidities at all, normal renal function, and lived close to the hospital. Only about 10% of their patients were admitted, and it was mostly just surgeon or patient preference. So they were only really comparing like 146 patients to 16 patients, but they showed no increase in readmission or complication rates. Their methods that I wanted to focus on, the patients were all reassessed by the primary surgeon 6 to 10 hours post-op, and then the patients all had direct access to the primary surgeon via phone call for any questions post-op 24/7. The patients were also followed up the night of surgery with a phone call, and then again at 1 and 4 weeks in clinic. Rosen et al. In 2024 reviewed over 1,250 cases in an ambulatory surgical center in Maryland. This study again kind of shows that the PCNLs can be performed as an outpatient. They had a 1.7% rate of needing to transfer patients to a hospital for admission. 166 of their patients had a BMI of over 40. They didn't find that increased their admission rates at all. They also didn't find that the only factor they found that increased the rate of or was a predictive factor for admission was stone burden, which like lengthened the OR and necessitated admission. But otherwise, their complication rates were quite low and in keeping with the current literature. For their methods, they limited their exposure to opioids. They employed a tubeless method with a DJ stent. They did an 11th and 12th rib intercostal block. And all patients received a phone call from the surgeon's office on post-op day 1, and then were followed up within 7 days for stent removal. So they also pushed the limits set by other authors. So they included patients of BMI over 40, and they included ASA scores of over 2 as well. So just to summarize the PCNL data, numerous studies have demonstrated that the safety of outpatient PCNLs, but with centers that are new to outpatient PCNLs, experience and logistical maneuvering will be needed before standardizing a protocol. Most studies have a follow-up within the first 24 hours, or they're on post-op day 0 or post-op day 1. And this could be feasible for some ambulatory centers, but for a high-volume academic center, I don't know how feasible it is. And then lastly, to note that the patient selection criteria keeps kind of expanding, and more patients are safe to be done as an outpatient. Next, prostatectomies. So radical perineal prostatectomy was the first surgery developed to treat prostate cancer. It was developed in the early 1900s. In the 1970s, the retropubic radical prostatectomy was developed. In the 1990s, some surgeons performed a pelvic lymph node via laparoscopy and then a concurrent perineal prostatectomy. And both the retropubic as well as the perineal approaches have been modified for outpatient approaches over time and have been found safe to do so. So Ruiz et al. Described 250 patients in 1997. His patients underwent a laparoscopic pelvic lymph node dissection and then a perineal prostatectomy. In their outpatients, the patients that went home the same day, they included 4 patients with a rectal perforation that was identified intraoperatively. Their average stay was about 2.7 nights, but their last 100 patients had a 91% same-day discharge. So again, they had this kind of increase of patients going home the same day over time. They didn't compare their data to inpatient procedures, but they had a very low complication rate. They had 0 readmissions and 0 take-backs and a 5% transfusion rate. They also sent questionnaires to all their patients post-op, and 94% of the patients were satisfied with their care. And again, notably, they employed a nursing team specifically for phone contact on post-op day 1 and to field calls from patients. Palmer et al. In 1996 first described a protocol to discharge radical retropubic prostatectomies on post-op day 0 to 1. They showed that their center's average admission went from 4.6 days to 1.7 days, with 35% actually going home the same day. Again, if you look at the graph at the top right, their kind of same-day discharge rates kind of went down over time and was more consistent over time. To do this, they had to really revamp their protocol. They switched to epidural only, no opioids. And again, the authors specify that for adequate follow-up, they employed a nursing team for preoperative and postoperative counseling. And since these studies, obviously, the minimally invasive approaches have become the standard with advancements in robot-assisted surgeries, and yet those patients are still treated on an inpatient basis. Saudi et al. In 2021 was published a meta-analysis reviewing 12 reports published comparing inpatient to outpatient routes, reviewing their failure to discharge rates and complications and readmissions. They found no differences in complications or readmissions between inpatient and outpatient routes throughout these 12 studies. And they confirmed that it's safe to discharge patients as long as their comorbidities weren't too severe. Their ASA scores were less than 2, their age less than 65, and BMI less than 30. But they did note specifically that across these 12 studies, for routine same-day discharge to be applied, patients required prehabilitation and education nurses, and as well as access to the team post-op. Aburezq et al. In 2019 compared 246 RALPs to 254 inpatient RALPs that were discharged the next day. So essentially, they had 500 RALPs, and they asked every patient, "Do you want to go home?" That was kind of their selection criteria, and about 50% of them went home and 50% stayed. They had no increase at all in the rates of readmission between in and outpatient routes. They had no increase in unscheduled office or emergency department visits. There was no increase in complication scores, complication broken down by the Clavian grade. And then another thing they noted and broke down was which patients were saying yes and which patients were saying no. And they found it was mostly correlated to which case of the day they were. So literally, like the first case of the day are way more likely to say, yes, I want to go home, compared to the third case of the day where you're done late in the afternoon and the patient would rather just spend the night. So yeah, again, something to note is that the patient had 24-hour access to contact a nurse or a surgeon at any point in time. They're also specifically instructed, don't go to the emergency department, call us first with any issues or questions. So to summarize for prostatectomies, outpatient prostatectomies have been studied and documented as safe to do so and effective in both the open and minimally invasive approaches. Consistently, studies show that same-day discharge rates decrease without protocols and employees in place for open access to the treating team and easy and quick early follow-up. And from a practical perspective, discharging patients is more feasible with cases early in the day. But again, it seems like the literature keeps showing that it's safe to do so, but there's a lot of hidden logistics. This is my only slide on nephrectomies. Open nephrectomies, patients historically had a length of stay of 3 to 5 days. And then in the 1990s, we developed minimally invasive nephrectomies, which decreased the average to about 2 days globally. Azawi et al. In 2016 performed a multi-center prospective study looking at the feasibility of outpatient minimally invasive nephrectomies. They looked at 105 patients, and patients just had to have family at home that are willing to provide care and had to live near the hospital. They had to be less than 70 and no cardiac diseases requiring post-op monitoring. And their OR had to end early in the day. None of their patients needed readmission, and 2 patients developed a surgical site infection. Otherwise, no other complications noted. And the authors noted that for outpatient nephrectomies to be standardized, patients must have direct connection to the treatment team, as well as reduced opioid use and good post-op pain control. So again, the patients had unfettered access to the surgical team 24/7 post-op. Polyps. So home enucleation of the prostate was developed as an excellent alternative to TURPs, specifically being effective in the setting of large prostates over 80 cc's, and it's been more and more popular in the recent years. The established literature says the length of stay on average is 1 to 2 days, and there are multiple studies that confirm that it's safe to do as an outpatient. So the largest outpatient HOLLOP study was by Lowen et al. In 2020, compared 199 outpatient HOLLOPs to 178 inpatients. They didn't set a limit on anticoagulation status or prostate size, unlike most of the current literature. And they found no difference in complication rates compared to current literature overall, and then specifically no difference between the inpatient and outpatient HOLLOPs. They also looked at symptoms and Euroflow score at 1 year follow-up and found no difference in their Qmax or symptoms or PVR. For their protocol, patients had the HOLLOP, ran CBI for an hour, and then went home with a catheter. And then they required access to nursing staff in clinic for a trial of void on post-op day 1. The second largest outpatient HOLLOP study was by Comat et al. It's a prospective study by one surgeon looking at his 90 patients that he did outpatient HOLLOPs on. All his surgeries were done at 8 a.m. HOLLOPs were sent home before 8 p.m. He excluded any patients that lived far away from a hospital, were comorbid, or had what he called inappropriate lifestyle. They didn't really expand on that. He didn't select based on prostate size. With their protocol, the CBI was run for 2 to 3 hours and then again sent home with a Foley. The patient received a phone call from a team member within 48 hours, and a nurse also went to the patient's home for a trial of void on post-op day 1. For their complication rates, about 14% didn't go home due to gross hematuria. One patient required a clot evac, but that was within 6 hours post-op. 3 patients required a transfusion. Their overall complication rate was about 36%, which is in keeping with the current literature. So they found it was overall safe to do HOLLOPs as an outpatient. Next is TURPs. The first resectoscope in TURP was developed in 1926 by Maximilian Stern. That's a picture of the resectoscope in the upper right corner. It had very limited coagulation ability. It was described by onlookers as you might as well be slicing the prostate with a knife. Since then, obviously, TURP equipment and methodology has come a long way, as have alternatives to the procedure. But despite options like HOLLOP and Resume and Greenlight, TURP remains the most common BPH procedure. TURPs actually represent 30% of urologists' workload globally. And traditionally, you admit the patient for 1 to 2 days for bladder irrigation, but multiple studies have attempted to confirm the safety of outpatient TURPs. Not really well documented. There's a lack of strong evidence supporting outpatient TURPs. There's some small scale studies individual center, but not a lot of big academic centers, not multiple ones at least. The first documented outpatient TURP in literature I found was actually from here in Vancouver, by doctors McLaughlin and Kinahan in 1990. They looked at 150 patients who had outpatient TURPs, all of which were younger than 70 and had no comorbidities. The patient and family decided whether they would prefer hospitalization or to undergo the procedure in an outpatient setting. The patients had CBI run for a total of 6 liters, and then were sent home with a Foley and instructed to maintain bed rest with bathroom privileges for the first couple of days. And then they TOV'd in, the trial avoid was in the urology clinic on post-op day 3 to 5. 5 of their patients required readmission as the bleeding didn't clear up with CBI, one of which was immediately post-op and 4 of which were delayed. They found that the prostate size didn't really correlate with a higher risk of hospitalization. And specifically, Doctors McLaughlin and Kinahan mentioned that they were pleasantly surprised with the ease with which the surgical day care staff adapted to the concept of being discharged the same day and closely supervising these patients. They said that the support was crucial to the feasibility of implementing outpatient discharge. Khan et al. In 2014 compared 60 outpatient to 60 inpatient TURPs with no differences in age or prostate size. They excluded any comorbid patients or patients with AKIs, previous treatments of prostate cancer. They gave all their patients Lasix to try to flush out some clots, and adequate hydration. They ran CBI for 4 hours, and they actually trial avoided before they sent the patient home. They sent the patient home without a Foley. They noted no complications at all in their outpatient TURPs and 1 stricture in their inpatient TURPs. Dr. Saint Laurent et al. In unpublished data from 2020 did a retrospective review of 187 patients for getting outpatient monopolar TURPs at the University of Laval compared to 175 inpatient TURPs. About 15% of their outpatient TURPs were admitted. It was mostly due to kind of surgeon clinical judgment, preference, and patient preference. They found no difference in terms of readmission or complications between inpatient and outpatient TURPs. No difference in ancillary procedures needed or emergency department visits. The outpatient TURPs were all done early in the day. They got 2 to 6 hours of CBI and then were sent home with a Foley and then trial avoid with a community nurse or a GP in 1 to 2 days. Their complication rates were similar to the inpatient TURP numbers. So in summary for BPH, HOLEPs have been demonstrated to be safely done on an outpatient basis. They're generally discharged with a Foley after some CBI. The 2 very large studies reviewed, or the 2 largest studies reviewed, showed prostate size and anticoagulation not to be obstacles to same-day discharge. And the biggest obstacle for logistics perspective seems to be the trial avoid post-op. TURPs don't have as much strong evidence solidifying their efficacy or safety. There's that no catheter discharge. The 2 studies outlined, TOVing before they sent home, but more evidence needs to be kind of solidified before this can be safely implemented. And then there are obviously lots of procedures that are developed with almost exclusive outpatient protocol. So UroLift, Resume, green light ablation, microwave therapy. But TURPs and HOLEPs remain a significantly higher prevalence due to either equipment accessibility, surgeon preference, surgeon experience, surgeon confidence in the procedure, patient preference. This is a very small scale study. I just included it to have a takeaway from the perioperative support needed to attempt a same-day discharge in a patient in a center that's not used to it. So a small scale study looked at in 2005 in Cleveland Clinic sought to attempt outpatient robot-assisted laparoscopic pyeloplasty in 6 patients. They carefully selected the patients. They were completely healthy, young people. They all got sent home with a DJ stent and no surgical drain. They required careful assessment pre and post-op, pre and post-op education. They had a call from the surgeon at the night of discharge. They had 24/7 access to the primary surgeon via phone call in the post-op period. So again, while this is a very small scale study, I just want to take away the peri-op support needed to attempt a safe day discharge, which may not be feasible in every system. the unfettered access to a primary surgeon, as well as the personal phone call to every patient the night of, may be feasible for 6 patients, but not at maybe not at a larger academic center volume. So, to summarize the limitations of what I'm thinking ambulatory surgery limitations are, while many of these studies concluded that same-day discharge is feasible, it's clear that they had access to supports not universally available. Given the high volumes of an academic center, calling every patient on post-op day 0 or post-op day 1, let alone giving patient full access to call you at any point in time is at any point in time they want to is not exactly feasible. You really need the infrastructure, you need the nursing support, you need someone to be fielding the follow-up calls, you need someone for trial avoiding, whether, you can't throw the trial avoid post-op day 0 or 1 all on GPs either. Many studies also determined that same-day discharge eligibility is based on surgeon comfort perioperatively rather than strict criteria. So that would come with experience sending patients home after these procedures. Patients need to be counseled perioperatively and provided ample literature, as well as access to perioperative nursing staff for any questions or access to the surgeon. The theoretical risk of miscomplications, it seems universal that complications are either picked up in the acute post-op period or days later. The length of stay of 1 to 2 days doesn't seem, at least from the literature that I reviewed, to contribute to avoiding these complications. So the risk of post-op delayed bleeds in a RALP is about 1.7%, and the risk of delayed bleeds in MIS nephrectomy is about less than 2%, so about the same. The question is whether an overnight stay for these patients and sending them home post-op day 1 early morning is going to actually decrease the morbidity or mortality. Another thing is post-surgical MIs. So post-surgical MIs are quite rare, with the global rate being like 5% for all non-cardiac surgeries. But obviously, having a cardiac history specifically is a strong predictive factor. So many studies excluded anyone with cardiac comorbidities specifically for this reason. And this selection criteria is probably difficult to argue against and difficult to ever expand. The mortality for a post-op MI is about 15 to 25%, and that's for patients that stay in hospital and get the MI detected in hospital. So the mortality is still quite high for those patients. Most studies also included a selection criteria excluding comorbid patients. Obviously, a large academic center like Vancouver sees lots of these patients. Another patient factor is patient preference. So to conclude, there's an established long-standing literature demonstrating outpatient surgery is feasible and safe in a variety of procedures, currently predominantly performed on an inpatient basis. These are driven by financial factors primarily, but also improve patient satisfaction, pain, and comfort. But despite this, many centers continue to admit these patients, which on first glance may be seen as unnecessary, but many of these studies describe established supports that are not always available and would otherwise require increased workload on physicians with no compensation to do so and no help to do so, or no established supports. One other thing I wanted to mention is kind of a devil advocate to myself is you could argue that a lot of these studies call back the patients on post-op day 0 or post-op day 1, and these check-ins are simply because this is a novel idea or something new to that center, and because this is a research study, you wouldn't really call back these patients, just like we don't call back ureteroscopies, even though that was at once a novel idea. But given that these surgeries have been done as an inpatient in these centers for years, for both patient and surgeon comfort, it's likely going to be still required, at least initially. And then additionally, a lot of these studies note that the unfettered access to the surgeon is the primary reason for the patients accepting the same-day discharge. It's a primary reason given that it provides both the surgeon and the patient comfort. And obviously, these studies don't unfortunately note, how often they're getting these calls, how necessary these calls are, how much or the volume that they're actually fielding, the extent of the support that was needed to actually field these calls. But I think that's a hidden logistics that isn't always commented on. And that's all. Thank you.